Ladies and gentlemen, esteemed colleagues, it is a pleasure and a privilege for me to be talking to you today from Tel Aviv, Israel, and sending my best regards over there to Korea. I would like to start my presentation today talking a little bit about how we are tackling COVID-19 and some of the lessons learned that one can take from Israel, a country which has had very interesting, I would say, response to the COVID-19 and is currently in a very dire condition, but still has some very interesting attributes to potentially learn from, both the things that were done well as well as those that were not. My name is Balicer. I'm a professor of public health at the University, and I also serve as the Chief Innovation Officer, as well as the Director of the Research Institute of Clalit Health Services, which is Israel's largest healthcare organization. And I'm also the chair of the National Expert Panel on COVID-19. So let's begin with no further ado. So this is a very famous picture of the 1918 pandemic. I think we all seen it at some point. And what we see here is one of the worst epidemics that mankind has seen, at least in the case of the sheer number of people killed in a single epidemic. And this specific disease was also unique as it was hitting in parallel to the First World War, and it was responsible for more casualties than the horrible war that happened at the same time. And it shows us what a pandemic can look like at its worst. But the next years, in the middle of the 20th century, we've seen amazing successes, antibiotics, vaccines, and here you can see the triumph over polio being shown to a person who's likely not going to benefit from it with an iron lung. And to the left hand, we can see the declaration of the World Health Organization in 1980 that smallpox is dead, and 78, and then in 80. And the fact that we could actually eradicate the disease has led a lot of people to understand that perhaps the age of infectious disease is maybe over. And as we have seen at the late 70s, it seems like that the relative importance of infectious disease is waning, and the percent of mortality that is caused by infectious diseases, which is the green part, is declining in a very substantial way. And it led some people to say the following. Now, this is the Surgeon General of the United States of America. He said in 1967, "It is time to close the book on infectious diseases, declare the war against pestilence won, and shift national resources to such chronic problems like cancer or heart disease." That was a little preliminary of a declaration we know today, but why? Why have we failed? Well, what we didn't take into account in the 1970s was more and more outbreaks of emerging and re-emerging infectious diseases. And we can see here a picture from about 10 years ago, which shows some of the new diseases that we've seen since the 80s. And you can see very different types of diseases here. You can see newly emerging diseases, those that were not recognized before, like SARS or H5N1 influenza, or what we see here as hantavirus and Hydra virus and Nipah and several other examples that are seen here. But not only that, we see re-emergence of diseases that we thought that we are going to, I don't know if to eradicate, but at least to control with antibiotics, yet multi-drug resistant bacteria continue to emerge. And there are many other examples we can give. But another thing that makes tackling infectious diseases more difficult today is because of global travel. And if we see here, this is a map of Europe, and it shows how bubonic plague in Europe on 1347 came across the shores of Southern Europe, and how it takes 4 years for the disease to move slowly from city to city, from country to country. And so this is one way that infectious disease spreads. And then we have the example of SARS just 17 years ago, with a dissemination that in 1 second it is in Hotel Metropole in Hong Kong, and then just a matter of days later, you can find it in totally different continents, in Canada and in Ireland and in Singapore and in Vietnam. And so this is how infectious diseases travel these days. And what we've said is that actually there's a new normal because the emergence of new infectious diseases, especially zoonotics that come from animals and move to humans, is becoming more and more prevalent, and we're getting used to it, and we call it the new normal. And the question is, what will be the next? What will be the next disease that we will experience? And we were all expecting for this. We were expecting bird flu. We were pretty sure the next pandemic is going to be an influenza pandemic and potentially a bird flu of high lethality, but that was not the case. And what we got is COVID-19. So when a new disease comes in, there's two key attributes one wants to understand very quickly because it will determine everything. And usually it takes quite a few months before you get those right. One is the infectivity and the other one is lethality. And there's a combination of these two will determine how the disease dissemination will look like. Diseases of, for instance, high infectivity and low lethality, like swine flu, in the beginning they cause a lot of fears, but once you understand they're non-lethal, you don't pay heed to them anymore. There's diseases like MERS with basic reproductive number below 1. It's a disease that stops itself, so it's not infectious. It's very lethal, but it's not very disseminable, and so it wanes off on its own. And then there's the archetype of the worst type, which is the Spanish flu, which is both infectious and lethal. And we'll talk a little bit about COVID-19 and ask how is the new disease faring on these two axes. There's also the question, two more questions about every disease is, what is the susceptibility of the young? For instance, in flu, the kids below the age of 6 months are very, very susceptible to a very severe disease. And kids in general are the main spreaders of the disease. And there's also the question of, is there or isn't there long-lasting immunity? Because that will determine a lot of whether we can hope for any herd immunity. And we'll talk about that today as well. So what happens in COVID-19? Lethality. Let's start with lethality. So almost 1 million people have been killed by the virus at the time this is recorded, and the numbers are climbing very quickly. We can see here in this graph that shows the relative proportion of different continents and different countries in the lethality, in the death toll. So you can see that very early in the beginning, the top was 6,796 death cases per day. And in those times, the key problem was in Europe. So Europe was a vast majority, plus the UK, a vast majority of those that have died. Now we're talking about 5,200 deaths per day. And the key countries that are now providing those are Latin America and India, and with a good contribution also from the US. So when we see this shifting over time, this brings a very interesting picture. So we can see how it moved at the beginning. Much of it was Europe, and at the very end, almost 40% right now comes from Latin America, and then about 25% more from Asia. So which countries are we looking at when we talk about the disease? So in terms of cases, not deaths, we can see that the 4 countries that have over 1 million deaths, 1 million cases so far, are the United States, India, Brazil, and the Russian Federation. So this is the case count, okay? You can see some other countries, Colombia, Peru, and Mexico over here. So these are the top cases. When we talk about deaths, it's a little different. So yes, still as a single country, the United States has the largest number of deaths with 200,000. But the next countries are Brazil and then India and Mexico. So these 2 countries that are not in the top in terms of the cases, they are on top in terms of numbers, sheer numbers of deaths. But this could be deceiving because these are countries of very different proportion, of very different size. When we try to see at the deaths per million, the picture is a little different. What this graph shows us in terms of cumulative cases is that the countries that have the highest number of cumulative deaths, this is deaths, not cases, this is mortality. The countries that have the highest number of deaths are indeed the United States, Brazil, India, and then Mexico. But when we do this cumulative death cases per million, what we can see here that the countries that have the most deaths per million are actually, you can see here in the top, Peru, Belgium, and Brazil. And then a country like India, which had a high number of deaths still as compared to the size of its population, is much, much lower on this scale. So different views according to different ways of looking at data. So let's talk about this virus for a second. So SARS-CoV-2, as it's called, is an RNA virus of the family of the coronaviruses. These include only 7 of the many hundreds of different coronaviruses are actually human viruses. And what it seems until now is that those other viruses, although they are similar to SARS-CoV-2, or the agent that causes COVID-19, have very little, if at all, cross-protection and cross-immunity with the SARS-CoV-2, with the COVID-19. That's very important because, as we'll see later, the issue of pre-existing immunity is very important to us. Now, the virus itself is similar, but only 80% similar to the original SARS virus from 2003. And one of the things that are most favorable about this horrible disease that is plaguing the entire world is that, as compared to other countries, like to other viruses like influenza or HIV, it has very few mutations. And so it is mutating, and we can see new mutations gaining traction in different parts of the world. But these are fairly infrequent and not as critical in the disease dissemination, and has not had an impact until now on the disease lethality. And this is very important. So when we think about the lethality, one should think not just about the numbers, but also on what is called case fatality rates and infected fatality rates. Infected fatality rates is basically the number of people that have died divided by the number of people who have been infected, whether or not they had symptoms or been identified through ongoing testing. Usually you find this denominator through serosurveys, through serology testing, and it is assessed that it is somewhere below 1%, the infected fatality rates of this disease. Between 0.1 and 0.7 would be a very careful assessment. In terms of case fatality rates, those cases that are identified or that are symptomatic, the case fatality rates vary dramatically between country to country, and in different countries, it varies according to the timing. Because, for instance, when the health system in a country is overwhelmed, the case fatality rates rise. And when the numbers go below the insufficiency level of the healthcare system, suddenly the case fatality rates are lower. And as we can see here on this graph, and maybe we should look at it a little larger, we can see here case fatality rates in several countries. And you can see here, for instance, that Italy has a fairly high case fatality rates. It might also be associated with the number of people being tested. The lower the number of people being tested, the higher the rate of the deceased from the total numbers. We can also see that Sweden had a very different level of case fatality rates. The beginning, very high because of the disease in the old people's homes and the elderly that got infected. Once they got it under control, case fatality rates went down tremendously. We can see South Korea over here with one of the lowest case fatality rates globally. And we can see Israel here with probably the lowest case fatality rates of any country. This is good, but as we'll see, if the case counts go too high, then that is not enough. So we talked about how lethal is this disease, but how effective is it? So in order to understand that, we will have to discuss 3 terms: basic reproductive number, dispersion parameter, and how likely the disease is to be airborne and be carried by aerosols. So we'll start with the basic reproductive number. This is something that people talk about a lot. They talk about R. So what is this R, or in this case, R naught? The basic reproductive number represents the number of people that an infected person would infect throughout its morbidity term until he is recovered. So if, for instance, every infected person, we can see the red one in the middle, infects 3 others, and these 3 in turn infect 3 others, etc., one can see how the disease dissemination goes quickly out of control. And this is the exponential growth that we're talking about. The higher R naught is, the quicker the dissemination will be, depending on the generation time. Now, this is basic reproductive number, which takes into account a population that has very little immunity, and also that homogeneous mixing is happening and people are not interfering with disease dissemination. But as we introduce masks and we introduce social distancing, and some of the population becomes immune to the illness after they've experienced it, at least for a while, then our effective reproductive number, the R for that specific moment, is reduced. The number of people that every person infects is reduced. And the aim is to reduce it below 1, because then the disease begins to subside. And we can see here, for instance, in Germany, how the R has been changing in time and going above 1 and below 1, depending on local outbreaks. It is quite difficult to calculate the reproductive number, because there might be different reproductive numbers based on the severe cases, based on the identified cases, and based on the deaths. So each one might create its own effective reproductive number. The next parameter I would like to speak about is what is called the dispersion parameter, or K. And that means given a certain reproductive number, knowing that on average, every person, for instance, would infect 1 person, then the disease might be disseminating very evenly, like you see here. Every person infects 3, or it could be that a small number of cases are super spreaders and infect a large number of other cases, while many cases have 0 or just 1 person infected, which is what we can see on the right-hand side of the screen. So the dispersion parameter is critical, and it is higher for flu, meaning that is more, there's fewer super spreaders. And in the case of, in case of COVID-19, the K is very low, which means we have a lot of super spreaders. We have a situation in which about 20% of the people infect 80% of all transmissions. And this is really important in order to understand how to control the disease, because if a disease is mainly transmitted through super spreading events, then if you dramatically reduce the likelihood of a mass gathering events, especially indoors, you are very likely to control the disease, more likely than if it was a disease that was very moving from person to person in a very mundane rate. But it also means that once you think you have everything under control, one case that goes to the wrong place and creates a super spread event with a mass gathering can completely change the dynamics of the disease. It is very susceptible to the few cases that create a lot of damage. So this is a key lesson learned in this case. The next issue that we talk about infectivity is whether or not the disease is airborne. Now, what does that mean? Usually, many of the respiratory diseases are transmitted by droplets. That means over 5 microns that are fairly large droplets that fall down very quickly. And they usually travel a distance of about 1 to 2 meters. And this is why the rule of 2 meters around every person in order to create social distancing and prevent dissemination. And it is true that there's a lot of dissemination in COVID-19 that takes place by droplets. But there's more and more evidence that also airborne or aerosols have an importance in transmitting the dissemination of COVID-19. And when someone sneezes, for instance, he creates an aerosol that can go as far as 7 to 8 meters. And so since we know now that there's also aerosolization of COVID-19, that makes a lot of difficulties in controlling the disease, even in social distancing, in the case of people crowding in closed rooms. And so it just makes it clear that in fighting the disease, we have to put a lot of effort on preventing gatherings in indoor settings, especially when they're not well ventilated. So this is very important to take into account. And so the transmission dynamics are very much dependent on 4 things: on the environment. If it's indoors or outdoors, is a huge, some people say 20-fold difference in the likelihood of infection. In the contact pattern, how close people were one to the other, what long of a duration was the contact, and what kind of activity was taking place. If somebody was singing or speaking or shouting, the likelihood of infection is much, much higher. The socioeconomic factors seem to be very important, and disease seems to disseminate more in the crowded, less affluent, lower socioeconomic classes in every country specifically. And finally, there's the issue of host factors. And we know that now that age has a huge impact on whether or not somebody would be infected, and when they're infected, what is the likelihood of a severe disease. And I will not show this today because this is too well known, but the disease mainly impacts the elderly and those with multiple chronic diseases. We will touch upon it a little bit later. So to finalize this famous, I think, graph from the B&J this year that have shown how different settings, what is the likelihood of dissemination in different settings according to some attributes. For instance, if it's a high occupancy setting and people are wearing face covering and it is happening indoors but in a well-ventilated area, then the likelihood is very low. But if you take the same high occupancy setting and it's in a poorly ventilated indoor setting and people are shouting or singing or praying, then suddenly it is a very high risk of dissemination. So we must remember this matrix, and you can freely go into the B&J in order to make decisions. People, for instance, ask, are outdoor gatherings safe? The answer is, it depends. If these are people that are standing outdoors in well-ventilated, high occupancy setting and they're silent, then it's very low transmission rates, very safe. If they're singing and shouting, then it is a medium risk. And if they are singing and shouting and they don't use masks, suddenly the risk is huge and is marked here red. So let's talk about a little bit about mitigation strategies. And basically, people are talking about two mitigation strategies that are very different from another. One says we have to flatten the curve. We have to flatten the curve because we don't want any health system to exceed its capacity, because the case fatality rates go up and people's lives are lost, and we have to stop all the economy. And so we have to be very careful and keep the disease at bay, very low. Other people suggest that maybe we should just let it pass through and try to get as many people infected as we can, because that would create herd immunity. So let's talk a little bit about herd immunity and how that works. So herd immunity, first of all, works on the concept of what is called indirect protection. And what is this indirect protection? It means that, let's suppose there's an R of 4, which means every person should infect 4 people. And let's suppose that 1 in every 4 persons is immune by that point. As you can see here, this person was supposed to infect 4. It only infects 3 because the first one is immune. And then each one of these infects 4, at least 3 of the 4. And as you can see, these 3 people were supposed to be infected, but they're not. So as you can see here, from these potentially 16 that should have been infected, 4 were directly protected by the immunization or by the vaccine or by the immunity, and 3 more were just protected by the indirect effect. Now, herd immunity is putting this to the extreme, which means, let's suppose in the same situation, 3 out of every 4 is immune. Well, this person was supposed to infect 4. He only infects 1. This one person was supposed to infect 4. But how many will he infect? Only 1. So in every generation, there's only 1 person being infected. And this means the disease is not disseminated, even though not everybody in the community is protected. And so this very strong indirect protection called herd immunity, which completely negates the option of dissemination, is very, it seems very, it makes a lot of sense. But in order to reach in COVID-19 herd immunity, the assessment is that we will take about 40 to 50% of the population to be immune in order to create proper herd immunity. And the meaning of reaching 50% immunity, or that 50% of the population would be infected, is horrible and detrimental in terms of the lives lost, because it always moves from the young to the older and the more vulnerable. And because even the young would have what is called now long COVID, which are the long-term complications that are now still being studied. And there's more and more evidence about neurological damages, about changes in the cardiac muscle, in the heart muscles, that might lead to long-term impact, a reduction in the lung function, in other problems in what is called long COVID. And so in Israel, what we were trying to do is to follow what was the concept of the hammer and the dance. And what we have tried to do is to prevent the immediate surplus mortality that would be expected from an uncontrolled dissemination at the beginning. So Israel created a full lockdown early on, very early, before almost any other country, and was able to almost completely negate the impact that was seen in many other parts of Europe. And we had very, as you will see in a second, we had very little impact of the first wave of COVID-19. And then the thought was that we would ease a lot of the restrictions, and we will try to keep the disease in what is called the lowest safety buffer, that would allow us not to cause the health system to collapse on one hand, but yet we will not reduce the activities in the community, because we don't want to be on what is called the overcautiousness threshold. To be below that would have an economic meltdown risk and too much damage to the economy that was already hit at the beginning. So we try to do this dance, and you can see here in blue is Israel, and in red is France. And so we've been able to curb the disease very early on, and you can see the difference between what happened in Israel and in France by the new deaths attributed to COVID-19. And then we made a mistake. We made a mistake because, this is pictures from the lockdown when we could see wildlife in our streets, and everybody is now using masks everywhere around Israel. So this is the good part. But what we have done is that in about May, it's just been, a complete laxing of all of the restrictions. And Israel entered a second wave of illness that you can see here that has begun in July and August, and you can see the number of deaths beginning to climb. And nowadays, we have actually crossed our safety threshold, and we are getting closer to the point in which our health system would begin to suffer, and we might see case fatality rates rise. So what we need to do now is to curb it down. This is why Israel went into a second lockdown just a few days ago, trying to curb it and bring it down again to where it was. So we're pretty much following what you can see here in this graph that was put down in April, and we're trying to control the disease now, and we hope it's not too late. But there's a very, very big difference, as you can see in Israel, between the number of cases per million, where Israel is #1 in the world in cases per million. Israel is over here in the top. And when we talk about deaths, cumulative, Israel is very low. You can see here Israel as compared to the EU, to France in deaths per million. And this is, by the way, South Korea, always at the best threshold that is there globally. And one has to really command what you've been able to achieve over there in Korea. And so why is the difference? And I would like to show why I think is the difference. And I think one thing is that we've done a lot of testing. You can see here the number of tests per 1,000 people. Israel is outside of the graph, much more than 5 tests per 1,000 people. And you can see the UK here, you can see Sweden here, and you can see South Korea here. You don't need a lot of tests because you don't have a lot of morbidity. But what we've tried to do is to do predictive modeling and predictive proactive care, like we do in chronic disease care. You can see here how we, in Israel, try to do predictive modeling on daily work, try to see who is at risk, that he has something bad that is going to happen to him. And we are able to see that and prevent it from happening early on. We do this on a daily basis. Instead of the patient calling the physician that he has a pain, the physician calls him and tries to prevent the disease by predictive modeling. We do this, for instance, for dialysis. Through artificial intelligence, we know which of our patients that look well and feel well will have deterioration of his kidneys, and we go ahead and we do proactive predictive care to them. And we tried to do the same thing for COVID. Very early on, we created a risk prediction model when using individual level data. When it was not available, we took it from other countries, and then when it was available, we created a risk point model that allowed us to identify and stratify the risk of everyone in the population. So those at the highest risk receive phone calls and SMS messages and different ways of approaching them, telling them to be safe, to stay home, and when the local dissemination is high, to stay home or to be very judicious about their work. And those with basic risk, they have less restrictions. And so this kind of a predictive, proactive approach helped us keep the elderly population of Israel fairly safe and allow us to keep the case fatalities fairly low, and even more so on the second wave as compared to the first one. You can see that in the first wave, about 17% +5, about 23% were either high risk or very high risk. And in the second wave, it was only 16%. So we've been able to protect our elderly better and prevent the mortality from them. And this is probably why our rates are still so very low, despite the high number of cases that we are detecting. So we have a very delicate balancing act still to do between allowing the economy to thrive on one hand and keeping the disease at bay on the other. We still haven't found the right equilibrium, but we're working very hard together. And I want to again thank you for hearing some of our lessons learned today. I want to again commend the achievements that you have done in controlling the disease in such low rates there. And I hope that some of the insights that were brought today would be of interest to you. So thank you and Godspeed.